I think we need to complete an integration of addiction treatment into and with the rest of the medical care system so that it really is treated as just another disease, and that the medical system is equally committed to treating, equally able to refer and manage patients with this disease the way they refer and manage patients with other diseases. There's more to addiction than just the medical treatment component to it, but leaving the addiction treatment system isolated the way it has been for the last 50 years, unaccountable for its results, unaccountable for integrating science in ways that other medicine has, I think is really wrong, and keeping addiction treatment separate from other aspects of mental health treatment as well as physical treatment does not serve patients very well.
David Rosenbloom, MD, is currently Professor of Public Health at the Boston University School of Public Health, where he focuses on U.S. and international health policy and issues relating to substance use disorders. His more than 40-year career spans the public, private, not-for-profit, and academic health sectors. From 1975 to 1983, as Commissioner of Health and Hospitals for the City of Boston, he was the city's public health officer and CEO of the city's public delivery system, including Boston City Hospital, 22 neighborhood health centers, and the emergency medical system. From 1984 to 1988, David was Vice President and then President of Health Data Institute, Inc., a company that pioneered the clinical analysis of medical claims data and developed managed care tools and techniques used throughout the country today. He's conducted, published research, and led national community-based demonstration projects in addiction prevention, treatment, and policy. He was the founder and director of Join Together, a program to assist communities throughout the country develop leadership and effective strategies to address addiction and gun violence. In 2015, David Rosenbloom, MD, helped found and serves as director of the Police-Assisted Addiction Recovery Institute.
I started in this in association with the Robert Wood Johnson Foundation, which in the late 80s was trying to develop a counterfoil to the cocaine crisis in the cities that was really leaving the cities, on the one hand, with a choice of violence or police crackdowns. And so the idea was, could we build a community coalition that would take responsibility for a strategy to prevent, treat, and set policy about issues of substance use disorders? And so what we started with in the Fighting Back program, which was a national competition to set up major strategies in a dozen cities, what we started with was an atmosphere of fear and loathing. And there was no recovery movement per se. What there was a police and law enforcement response to addiction. For alcohol and tobacco, which were and still are the major addictions, there was not much treatment. Most people who had these diseases didn't get any help, and all too often they wound up in the criminal justice system without any recourse or understanding that they had a disease underlying their behavior.
That caused all sorts of problems.
It was a problem that was completely divorced from the mainstream of medicine and really from the mainstream of legal reform.
So how did you get interested in the field?
I had been the Commissioner of Health and Hospitals for the City of Boston. We obviously had addiction problems, addiction realities. The fact was that a very substantial number of the beds that were occupied at the Boston City Hospital when I was its director were occupied by patients who had underlying addictive disorders, which were not being treated. They were being treated for some physical or mental exacerbation, but not for the underlying disease. And it was something that I recognized when I was there. We made modest steps to try to address it, but when the Johnson Foundation came along and said, we want to do this at scale, carefully monitored for our success, it was an intriguing opportunity.
What were you thinking of doing when you decided to enter the field?
This has actually never been my full-time job. Even working with the Johnson Foundation for almost 20 years, I was always doing something else. And so my role in all of this has been to help organize and mobilize communities to do the work and communities to do the strategies. And over this period of time, we've seen develop at the community level a very strong sense of lifetime recovery, a strong sense that, yeah, this really is a chronic relapsing condition that we will be engaged with as a recovery process for our lifetimes. And I think that the awareness of that has grown over the years that I've been involved.
So the 30-day experiment doesn't add up.
I have a curious experience with the 30-day experiment. For a while, I was the vice president and then president of a thing called the Health Data Institute. And we had as our clients major insurance companies and major employers around the country. And our job was to help them understand their healthcare costs and make recommendations for improving things. And one of the realities in those days was full coverage for 30 days of treatment at some alcohol recovery center. And these were good union policies, and so these were good benefits. And people took advantage of these benefits. One of the things we found, however, when we looked at the records, was in the vast majority of cases, there was no medical or clinical claim for alcohol or drug-related service before the 30 days, and none after the 30 days. And we also found that if the benefit didn't exist, then the use of these kinds of programs didn't exist. And so to a certain degree, our conclusion was that a lot of this early growth of the 30-day treatment stuff was benefit-driven, not clinically driven. And the reality of discharge with no follow-up led to rapid relapse for many of the people. It was an early lesson for me, and one which I think has stuck in my concerns about programs that don't have this lifetime attachment.
As you look over the decades, there's been a lot of money thrown at this.
There hasn't been a lot of money thrown at this. We spend, as a nation, we spend very little on a disease that affects so many people. So we haven't thrown much money at it. In fact, it wasn't even a covered benefit until the late 2000s when the Wellstone and Domenici bill and then the Affordable Care Act made it part of the basic benefit. So we haven't spent much money. When we were working with communities around the country, we had very enthusiastic support. And we had people who were in recovery who wanted to continue to give back, and we had other elements of the communities come forward. The thing that is new and exciting in this most recent few years has been the police departments around the country stepping forward saying what we've been doing for decades hasn't worked. We've ruined more lives than we've saved through our policing efforts. And so just today I came from a meeting with the chief of police who's instituting a very large-scale, important new program in a community where for the last few years people have been coming into the police station and been getting sent to treatment and not to jail. And so I see more and more of our social institutions recognizing how we need a new approach to this disease.
Are we at the tipping point?
I hope we are, but I still see far too many people who go into the first stage of recovery, which in this state is often detox, who experience negative effects in the detox experience, who come back out without further treatment, vulnerable to relapse, who relapse and die. And they are dying at the hands of the treatment system. So I hope we're at a tipping point, but I still see vast problems of stigma within the treatment system, stigma associated with the disease, and at the same time I see new actors coming in, and I see people actively recovering and leading good lives.
Where's the evidence of transformation in the prison for addicts?
Yeah, I think that what we're beginning to see in this state is a slow awakening that putting people into a jail without treatment and without arranging for continuing treatment when they get out, and they all get out, is just evil and wasteful and expensive. And so we've seen some legislation in this state which is trying to move evidence-based treatment into the jails and a couple of the prisons. We're seeing an increasing number of people being given effective medications prior to discharge and associated, attached to community-based treatment and recovery before they get out. Those things are quite hopeful. But the reality is almost everybody who's in a jail or a prison in the United States has an addiction, and very few of them to date are getting treated for it. We have to consider everything. We've got effective medications for some addictive disorders. We've got to get them into much, much wider use. We have people who aren't ready for recovery. We've got to keep them alive until they're ready for recovery. And so I think the mantra that I've come to believe in is we've got to keep people alive. And we've got to do whatever we can do to keep people alive. And if that is some form of supervised injection sites for some people, fine. They're going to stay alive. You cannot get a dead person into recovery.
What kind of pressures does the opioid crisis put on regular recovery?
That's an interesting question. I think that it's creating opportunities. I think that, it's a terrible epidemic, but the reality is that it is an epidemic which has affected a broader range of the society in smaller communities around the country that has generated more interest in this as a disease, and I think more sympathy for some of its victims. Part of this is racial and economic. When particularly the drug epidemic was erroneously seen as an epidemic of inner cities and minorities, and it's erroneous because it was never true. Whites have been the major users of heroin, cocaine, methamphetamine, and it doesn't discriminate against anybody. So the stereotypes were never true, but the reality is of the recent epidemic, which has in its early years tended to be more white, more suburban, more rural, I think that it has generated belatedly more public attention. And perhaps the recovery movement will find new support and new adherents as we begin to see that people can and must recover from these things.
What role does the government have moving forward?
Part of the current epidemic was facilitated by government inaction and stupidity, and by seeing these vast amounts of opioids being distributed and not doing anything about it. So government and the drug manufacturers and the pharmaceutical distributors and some retail pharmacies all have blood on their hands and all have responsibilities for major investments to undo this damage. Government clearly is a major important funder for treatment and recovery services. Governments can play a major role in providing both housing and job opportunities for people with addiction. Government criminal justice policies can undo the damage of a criminal conviction. You get a criminal conviction in this country, you are gone. You can't get a job, you can't get a place to live, and when that conviction has as its root a disease, it's just wrong. So government policy can do an awful lot to dig us out of the hole that we're in. You've been fortunate to interview what I would regard to be a unique subset of the people who work in addiction and recovery. That subset which has for 20 or 30 years been dedicated to trying to develop and use metrics of outcomes and lifetime improvement. They're not the majority of this field yet. The majority of this field is still working largely on an experience base, not a science base. The majority of this field, and by the way, the majority of lots of medical fields as well, has a paucity of outcome data. And so will outcome data make all of the difference in the world? No, but it will help. Does accountability for treatment results become a useful metric? Sure. But we probably already know enough about the effective medications and effective approaches to treatment that we now have, both medication and behavioral, to be much more rigorous in applying them. And we are not rigorous in applying them yet. And until we are, we're going to have too many people who have unsuccessful encounters with the treatment system and then write it off as not going to be helpful to them, when in fact it could be. And it doesn't. Lots of the stuff that people pay lots of money for doesn't work. And they know it. I have great respect for the AA movement. And as a recovery program, I know it's unfair to call it a program, but as an important element of recovery in many, many people's lives, it has played a very significant role. But it's not, as people in AA know, initial treatment for many, many people. We now have better initial treatments to prepare people for lifetime recovery, and that's what's not being used yet.
What other efforts do you feel could be made to try to decrease the stigma attached to it? You know, like we mentioned before, if a diabetic is diagnosed and he's told, change his diet, do this, do that.
And most of them don't.
Lose the weight.
Most of them don't. I mean, because these behavioral changes are really tough. I mean, let's not underestimate that this is a really hard disease. And I think that people who have no experience, I don't have any personal experience, but I've been around it for so long now. I think people who don't have any experience don't understand how tough it is. I mean, in some ways you're literally giving up your best friend, you're giving up your social community. So this is not easy stuff. And so even with these good treatments that I talk about, this is very hard, and you really need lots and lots of support and unremitting love to get through it. And so we don't recognize that enough. I've seen a lot of health professionals simultaneously tell me, yes, this is a disease with a biological, psychiatric, and emotional base, and there's something morally wrong with these people. I mean, so I've really seen too many people seemingly hold both views at the same time, and So yeah, I think that we continue to somehow or other think people with this disease are immoral. I see people with lots of other diseases who I'd call more immoral than this crowd, but
Touche.
I think that David Lewis has made an enormous contribution to this field for 50 years, starting as a clinician, understanding full well what the challenges of treatment were, and moving on to being, I think, the most creative policy leader in the country on this subject. And so I'm glad you've had a chance to meet him. The group that circles around Rick, I think, has been extraordinarily constructive in working to bring understanding and activism. I think Patrick Kennedy showed real bravery and courage in his using his own and his family's experience in trying to move public policy forward. And so I would say that he needs to be recognized for the contributions that he's made. One of the things we found, and we now have programs in more than 500 communities. We have more than 500 police departments doing this stuff. And one of the very interesting changes that I think are highly beneficial is that when a police chief or the person running the program calls a treatment provider, they respond. And I think that the chiefs have been surprised at how influential they are in being able to influence the behavior of the treatment community in their towns. And as they've reached out to develop relationships with the recovery community, many of whom had negative experiences with police departments, as you can imagine, that new partnership, I think, has real potential. And I've seen it in hundreds of communities around the country.
Well, we see by the mere fact that police and EMS people now have Narcan on them to be able to bring somebody back in the field is a beginning, a huge beginning, don't you think?
We have as a principal objective of PARI, the Police Assisted Addiction Recovery Initiative, that every officer will carry and be trained to use Narcan. And the chief that I talked to this morning said that every one of his officers has Narcan, and they're about to train and equip all of the meter maids in town with Narcan because they're on the streets, they see what's going on, and our recovery coaches, the PARI recovery coaches in communities around the country, carry Narcan with them and instruction kits when they go to the home of an overdose to do follow-up. They are training the family and the person who's overdosed on how to use Narcan, when to use Narcan. One of the harm reduction messages is don't use alone and don't use unless there's Narcan around. I think that that's a very useful and increasingly effective message. I think we need to complete an integration of addiction treatment into and with the rest of the medical care system so that it really is treated as just another disease, and that the medical system is equally committed to treating, equally able to refer and manage patients with this disease the way they refer and manage patients with other diseases. There's more to addiction than just the medical treatment component to it, but leaving the addiction treatment system isolated the way it has been for the last 50 years, unaccountable for its results, unaccountable for integrating science in ways that other medicine has, I think is really wrong. And keeping addiction treatment separate from other aspects of mental health treatment as well as physical treatment does not serve patients very well.